Let's wait. Maybe someone would like to share his experience about the exam. Okay. Okay. So let's start with some starters cases, and what do you see? How do you describe it? Okay. So still there is no response, but we can try to describe it like this focal lesion, right? And if you compare it with the renal parenchyma, so you can say that it is hypodense, perfect. And if you have, yeah, Nermine, perfect. So what would your differential diagnosis, what it will be? Yes, what is your differential diagnosis? Okay, I see many suggestions, which is good, but how you can start? I mean, any focal lesion in the kidney, and when it is indeterminate, so it will be what? It will be what until proved otherwise? Sure that the clinical have good thinking, but I mean, if you just see image and you see focal lesion in the kidney, which is in your character is indeterminate or maybe suspicious, or if you find any enhancements, it will be RCC until proved otherwise. Even in the ultrasound, sometimes it is hyperechoic. So RCC, it can present by many different types, but the rule that if you find any focal lesion in the kidney, then you will put RCC as top of your differential diagnosis. Then you try to characterize with many other images or sequences and so on. Okay. So this one, it was RCC, and the good issue about this is what is called Bosniak classification. So you need in Bosniak classification to check the post contrast image, which is here, and to see if there is any, yes, what to see in Bosniak, what you are searching, calcification or septation. Perfect. Yeah, enhancement, Ines, yes. So enhancement, if you mention enhancement, then you are going to which stage? 3 or 4? 4, perfect, Ines. So just if you mention enhancement, you are going to 4 stage or 4, yeah. So if non-enhancing solid component, you are going to be 3, yes. So what suggests, or what is the difference between 2F and 3? What is the difference between 2F and 3? Again, we can find something easier now. Okay. What about this one? Again, RCC. Why? Because we have here what? Solid component, which is look like enhancement. Perfect. Yes. So what happened with this renal tumor? Yeah, perfect. So Rihan and Nermeen, perfect, and yes, Ines. So very nice that you mentioned that the IVC is involved. So it's very important in the staging that, and I see that everyone know this. That's really nice because you can see the invasion of the IVC. So when you find this invasion of IVC, so probably it will not be less than stage 3. Perfect, 3C, yes. Perfect, doc. So at least we have this one, yes. So what happened here as a complication with RCC? Yes, hemorrhage. Why hemorrhage? Because we are in this phase, which is non-contrast. So if you compare this non-contrast with the appearance of this hyperdensity, so it have inside like high density, this means that maybe have hemorrhage. Okay, so this one, what happened here? What it have inside? Which sequence is this one, and what he want to show you? Yeah, in phase, out of phase, perfect. So in phase and out of phase, yes. Sorry, I'll just make some editing. Yes. In phase and out of phase, and you have what is called yes, fat and yes. Oh, okay, fat component, which is micro fat, or it is, which type of fat is it? Yeah, it is micro fat, yes, because you can see the drop of signal in the out of phase. Yes. Okay. This one I think is a bit easier one. Yes, you will mention that it is probably, yeah, bilateral multiple cysts. And again, pancreatic cyst, one of the good differential to put that this cyst also may be perfect RCC with von Hebel-Lindau. Yes. So it have cystic lesion in the head of pancreas, and it have bilateral renal cysts. So as you mentioned that it could be von Hebel-Lindau and with RCC as well. Yes, as you see here. Just I want to show you something because because I think what it in this presentation is a bit old version about the Bosniak classification. So let's just watch what is new. I think it's better to mention that the simple one, the Bosniak, is the simple cyst, as you mentioned, and the workout or the work up here, it would be nothing. Okay, Bosniak 2, it is minimally complex. So you have thin septation or thin calcification. Yes, and it is not measurable. And also the could be this high attenuation content, but less than 3 centimeters. So this is more detailed. And workup again, nothing. Percentage of malignancy will be 0. Okay. So again, Bosniak 2. So what is the difference between Bosniak 2 and 2F? This one and this one very similar, but maybe here you have some suspicious criteria, like if there is some increase in the septation, and they mentioned that maybe there is some thickening in the wall with some very minimal enhancement. Also, the hyperdensity cyst will be more than 3 centimeters, which here it will be less than 3 centimeters, and mostly intrarenal. So this what is require follow-up. So 2F depend in the follow-up, okay? And this 3 and 4, which is the suspicious one. So you need to check 3 or 4. 3, when you find like thick nodular septation, and here the updates that measurable enhancement, yes. And the treatment will be partial nephrectomy or RF. And percentage more than 50%. Bosniak 4, which have solid component, which is very clear. This one is like the most clear one when you find solid component with enhancement. So is it clear now? And I think they have this diagram, which is very beneficial to mention. Yes, that as you see here, when you talk about yes, 1 or 2 or 2F or 3 and 4, yes. So is it clear now? We can just go back to our yes presentation, continue a bit, and we will shift again. Okay. So again, when you find lesion, so you are talking about what? Yes, talking about cystic mass lesion which have calcification. Yes. So what is your differential diagnosis? Yeah, cystic renal cell, perfect. And they mentioned that if you find any calcification inside lesion in the kidney, so you should mention RCC until proved otherwise. Yes. So this will be the differential diagnosis. What else could be included other than yes, maybe you can just mention something called multilocular cystic nephroma. So they cannot be distinguished, as I mentioned, between RCC and the multicystic nephroma, but is good to mention if you know as a differential diagnosis. So what about this one, which you have ultrasound, and again you have cystic disease? Yes, what you are going to mention? Perfect. I like this asked question. What is the age? So if I mention that this patient is young age, what you are going to tell me? Okay, then I better show you this one. So this may be that he's in the pediatric age group. So what are you going to show me? Majida, welcome. So yeah, multicystic, but which multicystic one? It will be which multicystic? Yes. Perfect, doc. So this one, it is like a dysplasia. Yeah, type of dysplasia can happen in utero. Yes, it can be unilateral But if it happened bilateral, it would be incompatible with life. Perfect. Multicystic dysplastic kidney. When you find the macroscopic cysts, and this is non-communicating together. And I like the question of Nermeen that she asked about the age, because she wants to know if this patient is in pediatric. And when I showed you the MRI, you can recognize the spine of yes, pediatric age group. So we are talking about multicystic dysplastic kidney. Something to know, and they like it in the MCQ, yes, that the contralateral renal anomalies. So you have like UBG, obstruction, agenesis, and the multicystic dysplastic kidneys. Okay. This is also one of the MCQ and short question. Yes. What do you see? Yes, adrenal lesion. Perfect. So adrenal lesion, you need to characterize. Yeah. So what differential you would like to mention? Perfect. So adenoma, it will be one of the best differential. So let's show you this and what you will mention here. Perfect. So you need to check the other phases or the other images in different stages and different contrast stages. So you need to check pre-contrast and post-contrast, which is maybe arterial and venous and so on. Okay? Yeah, so do you have any other differential? Yeah. Perfect. So metastasis, Nermeen, Ines, Majida, nice. And what else? Yeah, it can be. Okay. Any other differential? Okay. So back again to this one. And this one, you should mention in differential. Perfect, Rehan. So you should mention hemorrhage. And take care, because it's not always, it will be hyperdense. It can be hypodense. Perfect. So yes, I agree with you, Nermeen. So it will be sometimes hypodense, especially in the other phases, like it is not hyperacute. Yes. So it can come to you later, and this one also was the same. So we have bilateral adrenal hemorrhage. So just to mention, yeah, I agree with you that you will mention adenoma and metastasis and so on, especially when you don't have the history. But again, you should. So if we mention that the hemorrhage, so what it will be the causes? Let's remember, it can be trauma. It can be what else? Yes, therapy, drugs, anticoagulant, sepsis, hypertension. Yes, post-infection like meningococcal or meningococcemia. Perfect. So just to know that, check the phase, and here, if you compare it to the venous phase, for example, it is hypodense, but maybe you don't see the pre-contrast, so maybe it is hyperdense in the pre-contrast. So one of the good differential to put the adrenal hemorrhage. Okay. Then there will be one good question about the calcification. When you find bilateral calcification, what is your differential? So it can be post-hemorrhage, post-infection, or metastasis, and treated like lymphoma and granuloma and so on, and idiopathic and something called Wolman. So this is what is called Wolman, when you find bilateral calcification, which is a rare case. Then we reach this one, And when you find it, you will suggest some differentials. So what it would be? Nermine. So why you mention Nermine that it will be myelolipoma? Perfect, because of the fat density. Perfect. So is it benign or malignant lesion, the myelolipoma? It is benign. Perfect. So fat and calcification well circumscribed, and this is the typical adrenal myelolipoma. Yes. I want to show you something. I think it will be a bit discussion, but let's see. Now we just make warming. Let's go in this case, and I hope everyone he will enjoy it. So when you find any abnormality, just mention it, okay? And try to describe it. Is it clear, the image? Oh, okay. So iPhone or Nermine. Sorry, we don't have any other images apart from this non-contrast images. Yes, perfect. Kareem, right iliac lesion with soft tissue component. How you describe this iliac lesion? Perfect, iPhone, yes. Yes, she is a female, about 45 or 50 years old. Narrow zone of transition, do you agree with this? I don't think that is, no. I think it's wide, because in many regions you cannot define this wide zone of transition, so it is aggressive, this description. So you describe it as aggressive lesion. I am looking for what you will miss. If you miss something, then you will miss in the exam some marks. Soft tissue component you mentioned, permeative lytic you mentioned. I am waiting. Okay, wide zone of transition, perfect. I am waiting something. What about the periosteal? Okay, perfect. Nermine, yes. And sorry, iPhone. Yeah, perfect. Nice. Now we describe this, and I will go with you until the end of this exam and come back again with you. So if any requests, for example, if you want to change the window, I agree with you. If you want to do anything, just ask me and I will show you, okay? So, so do you want to change the window because we will not come back? I'm waiting for your requests. Rihan, why you mentioned? Okay, yeah, nice to mention, Ines, that you will search for scale lesions in the other bones, but until now we didn't find anything. So soft tissue component, I agree with you. And as you see here, yes, the soft tissue component is obvious, and lytic lesion. And you should also describe if it is like reaching the articular surface or not, because I think it will affect the management if this patient, he have just this single lesion, okay? So you should mention this. So what you would like what you want to do. I hope that there is sagittal. I will try. Yeah, again. There is no hysterectomy, and if I go to the sagittal, maybe I can help you with the sagittal. I think the uterus is in its side. Do you see the uterus? So some question will not be asked. So take care, because if you ask this the examiner, for example, in the FRCR, that means that you lose marks, especially when you see the image. Okay. So Rihan, perfect. Where do you see this? Where do you see this? We have about 3 minutes. If you can hurry, because I want to finish this case before we shift to the next stage. Sagittal, okay. Bone window, why not? Okay. NA, where is the omental lesion? Where is it? Okay, in axial, perfect. Let's go to the axial. So, yeah, I will stop and try to, anyone can draw it. If you have the axis, Rabab, perfect Rabab. So, so what you are going to do? Perfect, nice. Who drew this? Very nice. I agree with you. So you can see clearly that there is peritoneal infiltration. So now what you are going to do? It is real, by the way, it's real case and real practice case. So I just want to make some brainstorm. So yeah, it can be, but the portion of the kidney that we saw it is not, yeah. And you're still missing something, but it's not very, yeah. So perfect, Rehan. I appreciate what you are doing today. So the ovary, go and check the ovary. Perfect. Maybe something there. Maybe. I'm not sure. But yes, I think that there is maybe something there. To be honest, until now is not confirmed this case, but it need further workup. Like that's one question. What is the workup from radiological point of view? I mean, for the clinician will be sure that he will check everything and he maybe request something. But from if just you have this image and you are surprised with this mass and this soft tissue lesion, and I wait from you to mention that there is also some para-aortic lymph nodes that it doesn't look like very well. Okay, so yeah, it can be indeterminate, but it looked like also that there is some lymph nodes. Or if they have like previous imaging, you are going to check the previous imaging and to compare, especially if you have like chest, abdomen, pelvis, or whole body. Then the best in this case is they request now like PET-CT. Okay. Anyone want to? Okay, if you want anyone to list. But just I want to show you the most important to not miss that the peritoneal nodules in this case that is very sometimes subtle. So look carefully in the fat. And unfortunately, this case was non-contrast. So you, yeah. And also about the ovarian, it can be just cyst and it can be something more. So that's what you need to check, that you need more and more. Let's show you something with very similar. So what do you see here? Yes, this patient, perfect, have omental cakes. Then in the CT, when you find this, just look behind the anterior abdominal wall muscles. Just in the layer after the muscles, you will find these omental cakes. And this is peritoneal disease. Then what you find here when he did PET CT, you find what? There is high uptake in the ovary. Yes. So take care. I mean that this case is a bit tricky. So as you see, and there is high uptake corresponding in the FDG. Okay. So yeah, this was a good case. Maybe I can show you this also, which is you can see that there is some uptake here in the this patient is old old female, and she have history of cancer. Yes, and as you see that there is uptake here, and he won't show you that this uptake is not convincing that it's high. Yeah, so here what happened? Yeah, bilateral ovarian lesion or masses. And again, you have other peritoneal deposit. Perfect, Ines. So Krakenberg, one of the good differential. Yes, we mentioned this. And in MRI, you can see that this patient clearly have this. Yes. So this was cecal tumor, GI tumor, colon cancer, and send metastasis to the peritoneum. So bilateral Krakenberg, perfect. So this was nice case. Let's have another case. So maybe in the MRI, you can see that there is bilateral masses. And in the PET CT, you remember we mentioned that the uptake surrounding the lesion. So the center, we called it like what? If you describe it in terms of hybrid imaging, we'll describe it as what? Photopenic, perfect, Nermin. And Rihan, perfect. So it will be photopenic center. And what in the MRI here? I'm checking in the answers. What in the MRI? MRI, look in the sequence, try to recognize which sequences. The fat here is suppressed or fat not suppressed? It is suppressed, perfect. So when it is suppressed, so you imagine that every fat in the image, it will be suppressed. So why here is high? That means that there is, yeah, nice. Yeah, perfect. So this was, yes, high content hemorrhage, bilateral endometrioma. Sorry, this one, yeah. It will be endometrioma. Okay, perfect, Rabab, iPhone, Jihan, I mean, nice discussion. So try to take it step by step, you'll reach your approach. Yes. So no, it's not Nermin Muhammad. Look in the fluid, any fluid signal here. It is low signal, so it is T1. It is T1, not T2. Okay? Look in the any fluid signal. So this one is T1 fat saturation. And when you find the high signal in T1 fat sat, you are talking about hemorrhage mainly. Okay? And when you find the hemorrhage, you can check the PET CT in the other side. It is photopenic, so mean this, they don't have any suspicious uptake. Okay? And this one was endometrioma. Okay? I will try to share with you this paper after we finish. Just remember me. It is very nice paper and everyone can read it. But okay, let's try to solve this one. What it will be? Nermeen, perfect. So the good differential to mention something. Why you mention something that have fibrous tissue? Why? Because when you go to the, yeah, the uptake, it is here, doesn't have uptake. Yes. But in this one, it have uptake. And where this lesion arise from? It arises from which? Which organ it look like coming from? Yes, good question. So the bowel here, it will be physiological uptake. This is physiological uptake, the bowel. And if you are like suspecting something, so maybe just colitis. But the urinary bladder and the bowel, this is like physiological uptake. Okay, so this comes from the uterus. So which very common lesion that it have fibrous tissue and it comes from the uterus, or maybe some similar to fibrous tissue. But so what it will be fibroid, and fibroid, as you know, that it have many shapes and many content that make it in the bed city that sometimes it have high uptake like this one, and sometimes it doesn't have uptake like this one. So you should be quite careful about the fibroid. That again, it's something very tricky. Okay. Then let's have this one, which is good case. And I hope everyone is enjoying this type of solve problem cases. So any focal lesion in the, it will be perfect. So try to fix to your rules. Yes, and where the metastasis here? Perfect. So it will be RCC, renal cell carcinoma. Even in the FDJ, it doesn't have severe uptake or high uptake, as you see. It's like mild to moderate. So sometimes the RCC, it doesn't show uptake, or maybe sometimes show low grade uptake. Yes. And here, yeah, that's why you can say that this one is stage 4, because it reached the bone. So okay, so this one, I will show you the answer to read it a bit, that it was coming by this lesions, bone metastasis, and he was unknown primary. Then when he did the FDG BET-CT, they find this lesion, which is, if you compare it with the other, it doesn't have this high uptake. But you can say low grade uptake, and in this case, it will be the renal cell carcinoma the cause. Okay, I just want to show you like different types of tumors and that how it look and how you can make interpretation. I hope that you are enjoying this type of questions. Okay, so what do you think here? So let's try to make one by one. So for example, here, if you go to the bladder and the CT, let's have a look in the bladder and CT. Yes, there is some different excretion between the right kidney and the left kidney, right? So probably the problem is here. Do you agree with me? Then when you look in the CT image, then you will find this mass. Yes, perfect. So you can suspect that there is maybe some hydronephrosis, or you can say that in the MEB, this MEB bit CT bit, you can mention that there is persistent nephrogram. Yes, probable, perfect. So there is something going with the excretion. If I told you that this patient, his history have colorectal cancer, so what happened with this patient? And he already treated. Yeah, invasion and recurrence. So the patient after he have this, and you can see clearly now that this patient have this tumor and it have like FDG uptake, and it present in the bit with different excretion by the kidneys, and then maybe you go to the CT to check, then you find that this patient already have this tumor which make the obstruction. And yes, sorry, yeah, let's go to this case. I have some trouble with connection, so this patient have a history of treated sigmoid cancer, and they have also like a high tumor markers. Yeah, they measure the SUV here, and it have like 10, so it's high uptake. So I mean the FDG. Are you agree with this answer still, or you will change? And they mention in the delay, this is the delay image. They mention that in the delay image it go for 15. Yeah, if you look in this image, I will agree with you, Nermeen, that it will be diverticulum because it's like the same excretion like the bladder. But when they make this delayed image, so maybe this now is different uptake. Yeah. So this mean that maybe if I told you that this patient is cancer, sigmoid cancer, then you can tell me that yes, it will be recurrence. Yeah. Perfect. So sometimes urinary excretion can hide, and you can mention that it is easier diverticulum, but sometimes it's not. Okay. Yes. So what's the difference between this and this? What happened? Yeah, what happened? Yes, thickening bladder. So where is it here? Where is it here? Yes, there is circumferential thickening. So it is masked when this excretion. It's similar to this case. It is masked in the excretion. Yes. So they take another image. Yes, I'll show you now this one. So what happened here? It is like a delayed image. Yeah. They make some windowing. Sorry, they don't make delayed image. They make windowing, but with SUV like 15, they make some windowing. Just manipulation of the window of the SUV for higher one. Then they try to make difference between the excretion of the bladder and the thickening. Yes. So it take the lateral wall, left lateral wall. So this was bladder cancer. Yes. So just I will show you some other cases. I think this one. Now it will be easier for you. I hope so. So this one, what it will be? And mention the finding. Please don't forget the finding, which is very important in this case. It can come to you long case, just colorful. Yes, robot. So it will be like RCC, IVC invasion, but here is tumoral invasion. You should mention that, as you see that the tumor have the same uptake like the invasion self inside the, yes, so bony mets, perfect. And the just, what else remaining? It will be, yes, the lymphadenopathy as well. Yes, perfect. So what about this case? Kareem. Oh, okay. Okay. I agree with you, Rabab, that it will be again in the kidney, so it will be renal cell, one of the good. And this type is like, they mentioned that it is diagnosed as something called clear cell carcinoma with sarcomatoid dedifferentiation. Yeah. Anyway, as you see that you should mention the metastasis, maybe the effusion, and the hepatic focal lesion, which is obvious here in the CT and the PET CT as well. And yes, perfect. And again in the right paratracheal, upper paratracheal lymphadenopathy. Okay. Okay, let's go to this one, and I hope everyone is still enjoying. Is okay. With much webinars, then it will be sometimes is exhausting for us. So yes, horseshoe kidney, and you see the normal uptake of the kidneys. So don't miss it. And in the MIB image, sometimes give you this. So this is like anomaly, horseshoe kidney, perfect. There is some uptake, which is physiological uptake. If you find this like a lesion here, then you can talk about something, but you don't find until now. Okay. Yes. So I want to hide this, but okay, it show you. So just I want to show you the MIP. What happened here? Oops, I show you the answer. Okay. Yeah. So it can be like a crossed fused ectopia. Maybe you see the answer. Okay. And yeah, he have like a single renal unit. So what is the reason? It was because that there is cross diffused ectopia. Yes. Then when you find, yeah, Already the patient have something. Yes, Ala, perfect. This patient have lymphadenopathy, axillary and inguinal. So axillary and inguinal. So already this patient have lymphadenopathy, and the most common, or one of the most common causes will be lymphoma. So this patient is patient of lymphoma, but already have like other anomaly, which is incidental. Yes. Okay. Let's have a look in this case. Yes. So no uptake, perfect. And you can see that the kidney itself, it have slight low grade uptake. So this like normal physiological. But when you gave the contrast, this was the pre-contrast image. And when you give the contrast, what happened in this patient? What it have? Enhancement. So which is it? Which Bosniak you have, or which differential you can mention? It will be RCC. Yes, it will be the most common one. It will be RCC. So sometimes, as you see, the renal cell carcinoma, sometimes it can take high uptake, and sometimes it cannot take high uptake. So be careful about this, okay? And it can have low grade uptake, yes. And I hope that you enjoy this case as well, okay? What did you describe here? I think it's the easy one. Rihan, they don't mention the pathology. Sorry. Yeah, bony metastasis. Yeah, perfect. And okay. Yeah, renal to bone. What is the something that make you sometimes here is like confusing? That the uptake here, is it higher than the primary tumor or lower than the primary tumor? Do you see the uptake in the metastasis? Is it higher than the primary tumor or is lower than? Yeah, it's higher than the primary tumor. So sometimes it's tricky and make you confusing. Is it like the primary or not? But when you go and check the CT and you see that there is renal mass, so it will be the origin. So as you see, sometimes it doesn't have, yes, okay? It doesn't have, so this renal, it was renal cell carcinoma metastatic to the bone, okay? Yes, what about this one? Why you mentioned this? Yeah, he wants to show you at the CT, there is something here in the renal pelvis. So the most common cause of renal pelvic tumor, it will be the transitional cell carcinoma and metastatic to the liver. You can see very subtle that there is lesion here, but in the PET CT, it's easier to recognize it, right? So again, sorry. So what is going here? This is very, very nice image. When you try to read it in the textbook, you will find that Yeah, Ala, I want one very good term. I want you to mention. Look in the ureter here. What happened here? Yes, synchronous transitional cell carcinoma will be one of the good things to mention here. That you find multi lesions in the bladder and the ureters, and they like to mention this drop metastasis. Drop metastasis. Yes. So synchronous transitional cell carcinoma or multifocal transitional cell carcinoma. Okay. So yeah, here the high uptake inside the ureter. This is from the tumor metabolism. So it will be different from the X-ray. Okay. We will go to the X-ray after if we are lucky to continue today, but you will find that it's different. Yeah, this one we are talking about the tumor metabolism, which is higher here. Then you are diagnosing that it is transitional cell carcinoma with drop metastasis. I hope everyone enjoy this. Let's go to the some few cases before we finish our session today. I want to ask again this question I asked you in the first. If there is anyone who passed the exam, sorry, even one take the exam in the 15th of August, Cairo, can just give us the feedback. Ines, Amr, the others who have this exam just can either mention in the chat or he can just take the mic. Ines, okay. So the most problematic question, it was about the physics. Because yeah, was annoying physics questions. Yes. So it was like a deep question in physics or just, and it was in the X-ray or CT and MRI. What type of questions? All, yes. So be careful about the physics. Yeah. You can check the case. What about the long cases? Yeah. Okay, I will follow your chat until you write. You continue writing in the chat, and I will discuss this case and come back to you to. Okay, let's go. So this what we have. Left adrenal. Continue writing, Ines, and I will discuss in last 4 minutes your chat answers about the exam. Okay. Thank you. I hope that everyone can have benefit from this feedback here. So you have left adrenal mass. Then you will put differential diagnosis. If I show you this MRI picture, then Nirmin Muhammad, I think now you can see the difference between T1 fat set and T2 fat set. So T2 fat set, look in anything have T2 signal, like the CSF, for example, or the gallbladder. Then you can see easily that it's high signal, yes. So it is high, very high T2 signal, this lesion. So yes, it will be light bulb sign, Abbas, perfect. So it will be pheochromocytoma. Yeah. Perfect, Sarah. Nice. Perfect. And they like to show you something in nuclear uptake. Then finally, again, it can be very high. So this is the pheochromocytoma. Yes. So it can be bilateral. And if it is bilateral, it is men. Which type of men? Yeah, multiple Endocrine tumors, yeah, yes, it will be MEN 2, MEN 2. A or B, yes. And it can also be included in von Hippel-Lindau, neurofibromatosis. It can be even extra-adrenal, as you know. And is it benign or malignant? Yeah. Yes, rule of 10, Rehan, perfect. So the rule of 10, bilaterality, hereditary, extra-adrenal, and malignant in 10%. Perfect, Nirmin. Very nice. And in the MIBG, in the nuclear, it have like high sensitivity for it. So you can know that it is pheochromocytoma. Yes. Very nice discussion. Sorry, I showed the answer, so it's nice. Then, okay. So everyone can see the feedback of the exam now from Ines. They have some fractures, something in the renal, FNH. Okay. What else, Ines? Yeah. Mesothelioma, left cardiac myoma, silicon granuloma. I think this one we have similar in our revision, and this also, and I think this one as well, if I'm not mistaken. And yeah, we mentioned many aneurysms in the revision. Yes. What else in the long? Yeah. Okay. So yeah, like very nice. Carcinoid, which we discuss in details. Cardiac myxoma, perfect. Liver metastasis. Yeah, nice. Let's go to this case, which it have like adenoma. So how you can approach the adenoma? Yeah, in phase or out of phase signal. So you go and you find that there is drop of signal in the out of phase. So this picture or this image, it is out of phase. So you can see the darkness in both adrenals here and here. Yes. So bilateral adrenal adenoma. So this means it have micro fat or microlipid, and there is loss of signal. And there is something called absolute washout, and this you can use it in the CT, and relative washout, yes. And they have this equation, as you know, about the absolute and the relative washout. I think if you read it, the text, you can. The most important to know that they measure the Hounsfield unit in enhancing, yes, and non-enhancing, yes, and you can measure it. And the threshold of 60% or higher for absolute washout, or for the relative, it will be 40% or more, yes. So it will be adenoma. So how you can know the out of phase? This one question, yes, it will be the paper ink artifact or chemical shift artifact, yes. Thank you, Ines. Alhamdulillah, that the most important, I think, inshallah, you will pass the exam, because most of the long questions, if it is passed, then you, inshallah, you will pass it, okay? Lipid-rich adenoma, yeah. So also they have otitis media, sigmoid thrombosis. So this one, we already mentioned this case in our revision, and I stress in this, alhamdulillah. So it was nice, because it's really, it is important, the real practice, more than the exam view. This one, otitis media and sigmoid thrombosis. I just read from the chat, because when you hear the lecture, you can in the recording, inshallah. So this was the cases of the lung. We can just mention it again. Cardiac myxoma, carcinoid, liver metastasis, otitis media with sigmoid thrombosis, focal nodular hyperplasia, subcapsular hematoma renal, fracture wrist, metacarpal hamate. Okay, and I think you mentioned mesothelioma, left cardiac myoma, silicon granuloma, cavernous internal carotid artery aneurysm. Okay, I think I read all what you write. Yes? Okay. Okay. Let's go to this case. With this as a differential of adrenal adenoma, sometimes the metastasis, especially from what? It can give you similar appearance to adenoma. It will be metastasis from lung. Yes, Rehan. So when you find this, again here, the helpful sequence will be the out of phase. Then, yes, that no drop of signal here. So compare this one with this one, which you can see the drop of signal in the adenoma, which is easier. But in the metastasis, there is no drop of signal, which is the typical one. Okay, the typical. So again, when you find adrenal lesion, so your differential will be adenoma, metastasis, and we mentioned hemorrhage in these cases before, myelolipoma, pheochromocytoma, granulomatous disease. Yes. Yeah. So let's go lymphoma. Yeah. Primary tumor. Yeah. As well. Yeah. Okay. Neuroblastoma. Primary tumor, like what? Primary cancer, like what? You can find this large lesion. When you find large lesion in the adrenal, either it is pheochromocytoma, but when it is more bigger and there is invasion, and you can see that there is some invasion of the IVC, so you are talking about what is called adrenal cortical carcinoma. Let's finish our session today for this. I hope everyone enjoy this type of discussion. If you agree, just vote in the group, inshallah. We can continue in the same method. If you don't agree, just send me your suggestion and we can modulate, inshallah. See you, inshallah, maybe in Wednesday. If it's okay, we can see, inshallah. Yes. Any question before we go? Yes, okay. Let's start with this case. Okay. I hope that everyone is enjoying. So let's start. I think this one is starter case. It's easy, inshallah, to just warm up. So what he described, how he described this, what is happening in this image. I'm trying to focus. So you can see that there is some contrast. So what do you think about this contrast? Is it like a delayed image? Yes, Rihan, Dua, Ines, mashallah, hello. I hope everyone is fine. Mashallah, our stars, they are ready. So it is extraperitoneal bladder rupture. Why extraperitoneal? Why do you think that it is extraperitoneal? Yes. Why? Because like bladder classification of rupture, either intraperitoneal or extraperitoneal. Perfect. And this one, it looked like extraperitoneal. Yeah. So if I show you this one, it will be intraperitoneal. How you can differentiate between both? If extended to the thigh, it is extraperitoneal. Perfect. It's good. And if it is surrounding the bowel loops, Yeah, it is intraperitoneal. Perfect. So if it is surrounding the bowel loops as is here, it is intraperitoneal, paracolic gutter. Yes, perfect. Rihan. Ala, yes. Yeah. They like to show you this also as the beer-shaped appearance. This is like frontal IVB with the teardrop or beer-shaped bladder. Yes. So yeah, it can be, as you see the description, it can be lipomatosis, hematoma, urinoma, lymphocele. It depends on the content of the pelvis and what it should have. Yes. Lymph node or psoas muscle atrophy. Perfect. So this is like unto many cases come to you as short. Again, extraperitoneal rupture. And they have classification. Let's check it, revise it. So 1, it is like bladder contusion. 2, it is intraperitoneal. And 3, it is interstitial. And they have 4A and 4B, which is simple or complex, and 5 is combined injury. Okay. And again, this one, it is intraperitoneal rupture. They like to show you this pear-shaped to put the differential, what the content surrounding the bladder. And yes, so what will be this one, which is a bit easier one again. So that will be the description of the exam itself. It's fine that you can see the full catheter here, and this is right retrograde urethrogram. So when he show you that this is urethrogram, then you expect that he won't show you this happening with extravasation. So your question about the history, it will be asking for if this patient have trauma. Yes. And yeah, so it is urethral injury. Nice. Perfect. At the level of urogenital diaphragm. So it is above or below or both sides. It look like both sides of urogenital diaphragm. Both sides. Perfect, Ella. So in this type, you are talking about urethral injury, and if you want to classify, maybe you can give it like 3. Yes. Because it's above and below. Yes. So nice. Let's check it. So this is what's called urethral injury. Yeah. The most important to know that no Foley's placement before excluding urethral injury. Okay. And the classification of urethral injury. Okay. So what about this one? What it will be? So if I told you that this is history of trauma and it is, yeah, type 1 urethral injury. So there is something like minimal stretching or luminal irregularity of the posterior urethra, and there is no extravasation. So it is type 1. And if I show you this one, which type it is, then yeah, perfect. Dr. Muayyad, welcome. We have new stars today. Okay, retrograde urethrogram type. Which type? This one. There is disruption here. Yes. Yeah. and there is extravasation of contrast material. So type 2, Dr. Muayyad, perfect. Type 2, yes. It's coming from the posterior urethra, yes. Okay, and it should be superior to the urogenital diaphragm, so it is type 2, yes. To be honest, this in the exam is not very detailed like this. I mean, they don't ask about the classifications, but okay, let's have a look. Okay, so this one again, retrograde urethrogram, as you see, and here you can see that there is this disruption, and yeah, the contrast extravasated, and this one it will be maybe type 3 or type 4. Yeah, perfect. So this one is like between type 3 and 4, perfect. And finally, what is called is this one, it is called something like antimony in this retrograde urethrogram. You can see that there is extravasation at the level of bulbous urethra. So let's remember the anterior urethra, it is from prostatic and membranous. Let's have a look, because maybe I know that it's not very. So the anterior urethra, it is from the bulbous and benign part. And the posterior urethra, it is the part of prostatic and membranous. So do you agree with this? Let's have a look here, for example. So this part is anterior part, it is what is called bulbous and benign. This is the anterior. So the posterior part will be the prostatic and the membranous. Okay. So in this one, which is type 5, perfect. It will be the benign bulbous, yes, bulbous urethra, distal bulbous type, yes. So it will be type 5, which is called straddle injury. So let's check again. Type 5 straddle injury, yeah, involve the bulbous urethra. Okay, I know that's much details, but we can trying to just recognize at least the anterior urethra from the posterior urethra. So this one, yes, it is in the bulbous urethra. Okay, so again, the anterior part, anterior urethra is bulbous and benign. Posterior part is prostatic and membranous. Okay, there is some details, you can read it. Okay, let's shift to this one. And what is the abnormality here? I see some absent stars today. Nirmini is here, yeah, okay. Drivan, iPhone, where is iPhone? Okay, we'll take in the final checklist, inshallah. Who come or who absent today? Okay. So persistent nephrogram, perfect. So this one, what is called persistent nephrogram. So what is the differential when you find bilateral persistent nephrogram? Yeah, differential diagnosis. If it is bilateral or unilateral. So in this case, it is bilateral, as you see. So yeah, what is your differential? Contrast reaction, maybe. Nice. Yeah, acute tubular necrosis, hypotension is good cases. And maybe if it is unilateral, but it's not in this case, you can think about renal artery or renal vein thrombosis and obstruction and pyelonephritis. If it is unilateral, not bilateral, okay? Perfect. And if it's unilateral segmental, like it's affect part from the kidney, not all. So maybe it is like focal obstruction, the same, but it is focal infection, focal obstructions, focal restriction, okay? That's nice. Let's go to this case. And you can see that there is focal renal lesion which have it have ML. Why angiomyolipoma? I know that's easy question, but it's because there is vessel and there is fat density, and the most common to be with this appearance as antimony case, it will be the angiomyolipoma. Yes, with prominent vessel. Can the RCC have fat? Yes. The question is yes. The answer it will be yes. Okay. Nermeen, yes. Welcome back. So what do you see here? And what is your description? Why tuberous? Multiple bilateral AML. Perfect. Multiple bilateral AML. What happened with this patient? There is, there is what happened? Rupture. Perfect, Nermeen. Ines, nice. So what happened is rupture, because you can see that there is collection outside or adjacent to the right aspect here. Yes, so this collection and here, yes, ascites. So that means that this patient have rupture AML. So this is one of the complication, as you know. They say that the risk of rupture increase with the size. Do you agree? Yeah, Rihan, perfect. What is the Wunderlich syndrome, Ala? Can you explain in voice or in chat? Let's share the benefit. Yeah, more than 5 centimeter, it will be hemorrhage. Yeah, more than 4 or 5 centimeter. Yeah. Okay. So if more than 5 centimeter in size, it will be risk for rupture. Okay. Some of this type have lipid gore, so you cannot see fat of AML. So rupture AML with perirenal hematoma. This is what is called Wunderlich syndrome. Oh, something good to know. Okay, thank you. So this is what is called angiomyolipoma. Yes. Okay. Secondary to consuming DIC. Okay. What is DIC? It is like pills or contraceptive pills or something related to maybe. What is DIC? Nermeen, what is this? Okay, let's shift to the next until you respond. Okay. Triad of Wunderlich. DIC, disseminated intravascular thrombosis, Rabab. Okay. Thank you. Thank you for this information about Wunderlich syndrome. We can Google it and see what is Wunderlich. Okay. What about this case? So this is like retrograde bielogram, and what you have here, it is like hydronephrosis. Yes. And I see that someone mentioned that is goblet sign of ureter, transitional cell carcinoma. Yeah. So where is the goblet sign? Yeah.
عفوا دكتور، هو الدايليتيشن اللي هو ديستال للفلنج ديفكت اللي موجود بالرايت سايد بيكتشر.
Yes.
موجود فلنج ديفكت in upper part and there is dilatation and they look like goblets.
Perfect. So in the upper and lower half of the right, there is like hydronephrosis, and there is ferric defect, yes, at the head of contrast, yeah. It's called goblet, yeah. So there is dilatation, but it's distal to the mass. So you can suggest that it is filling defect, and this filling defect, one of them, it will be the transitional cell carcinoma. Okay. So the most common site for transitional cell will be bladder or kidney or ureter. Bladder. Then what? The kidneys or the ureter? Okay, renal pelvis, perfect. Yeah, this is like MCQ questions, so take care because they like it. Yeah, then the ureter. Yes, then so the most common the bladder, then the pelvis of the kidney, so the kidney pelvis. Yeah, bladder, pelvis, then ureter, and the proximal urethra. Yes. So the most common the bladder, then the kidney, the renal pelvis, and finally the ureter and the proximal urethra. Okay, and we mentioned this type last session, which is synchronous or metachronous. That's why when you find one transitional cell, you should search for others. Do you agree? Okay. So, for example, here you find it in the bladder with polypoidal appearance, and if you go here, you will find it like infiltrative appearance. Yes. Again, it can be in the kidney, so it is in the pelvic cell system. It is again transitional cell carcinoma. This is have a sign when you see the kidney like this. It is called, when you don't find the central sinus, there is absence of the central sinus here, and there is some stranding that you should comment in it in your report when you have the comment. And as you see, this is non-contrast, and this one, it is post-contrast, and you can see also the calyceal excretion. So there is mass here. So this what is called in the sign, what is called I'm waiting. Okay, what is called, yeah, faceless or ghost kidney. Yeah, like you don't see any anatomical differentiation in the kidney. It's like faceless kidney, and you can see that the central sinus is lost. So this is what is called renal cell transitional cell carcinoma, faceless kidney. Okay, yeah, nice to know. Then I will show you like maybe this one. So what happened here when you describe it, how you describe it? Yeah, Ala. Okay, you are so fast, mashallah. And Nermin, yeah, you have to. Where is Marwa? Marwa is absent today. Okay, so we have diverticulum and we have soft tissue lesion, yes. And it is like diverticulum, and on top have transitional cell carcinoma. Perfect. And this is the differential we mentioned before about the urethral filling defect. This can be like infection as fungus, urethritis cystica, clots, polyp, endometriosis, stones, slough, tumor, and TB. Okay? Yes. So this one, it was non-contrast, as you see. Then this patient, he have a supine position, and then he have this appearance. So what is your differential? Nermeen, perfect. Perfect, Ala. Yeah, so what happened? Because it changed the location. So changing the location means that is blood. Yeah, so it is one of the good differential to put. It will be hematoma. Nice. And something nice to know that you can put also in the differential diagnosis something like this when you have this appearance. And maybe you can note that the signal in pattern of this lesion in at least this image of T2, it is similar to something like the muscles here. So then you can, yeah, it is low signal. Yes, perfect. So you can put something in differential diagnosis, include perfect Nermeen. Yeah, it is leiomyoma. Yeah, you can put leiomyoma as a good differential diagnosis. Okay, perfect. So again, something maybe very rare to know, just to know that it can also include here that pheochromocytoma. Yes, and as Ala mentioned, that is highly or avid contrast. It is avid to contrast, so you can imagine that is a vascular tumor or something related to, yeah, paragangliomas. Yeah, perfect. So this one is, I think, it's easier one. When you find this hydronephrosis, is it true what I mentioned? Is it hydronephrosis? No, yeah, perfect. So it is right staghorn stone. Yeah, this you should look that it is Blaineux. See Blaineux, and there is no contrast, so it is easier one to mention that it is staghorn stone. So it is like making, when you report it, you will mention important term. What you will mention in your report when you describe it? How you can mention it? You will mention just staghorn stone. Yeah, it is casting or filling the calyces, branching and casting the calyces. So this is what's called staghorn stone. So again, what happened here in this IVB? Where is Abbas today? Abbas, and we have many absent stars today. Okay. So you can see that there is in the IVB something here with mild, yes, the mid portion, yeah. It have something here, yeah. Yeah, pouch filled with contrast. Yes, perfect. So what is your differential, Rihan? Ala, perfect. It can be stone in diverticulum. Yes, it can be stone in diverticulum. Then you can expect in the CT when you find any pouch that is filled with contrast excretion like this, and you have the previous non-contrast, and yeah, you can think that it is diverticulum or what is called hydrocalicosis. Yes, Dr. Muayyad. Abbas is here. Okay, welcome. So this calyceal diverticulum with stones have different shapes. In the BUT, you can see this one, and you can see the dilatation of calyces surrounding the stone. So this is, even in the practice, you will see it much. So this is what is called calyceal diverticulum with stones. Then if you are lucky in one of your shifts in emergency, or maybe in one of the radiology nights, and you are sitting and you make ultrasound for some patient or one patient, then you find this appearance how describe it? Yes, Ala. Then you probably was one of this lucky radiologists who have this appearance in the emergency. So yes, it is dilatation, and you have debris, and you can see the posterior acoustic enhancement. So one of the good differential to put, it is bionephrosis, which is important, very important to know. And what it will be, the management in this case, it will be radiologist rule, which is interventional radiologist need to do nephrostomy. Perfect. Percutaneous nephrostomy. Perfect. BCN MacBook. Who is MacBook today? Okay, thank you. Let's go and see. Yes, this one. Then in the next session, we will go to the hybrid imaging modalities. Okay, so what you have here, yeah, I want the term of IVB term. What is here in IVB term? You how what is your imagination about this IVB? Okay. Okay, maybe you can start. Okay, let's start with this. Okay. So what, do you have anything here? Yes, it's simple that you have a stone, and this is what is called persistent or holding of contrast of column, urethral contrast column. Yes. So when you find this holding compared to the other side, you don't have this. So you are imagining that maybe there is stone here. Then go to the IVB, look. If there is any stone obstructing this, then you know that this contrast is holded, or this column of contrast is holded by nephroic lithiasis. Perfect. Or stone, yeah. So the column of contrast, it can be dilated or even minimally dilated, as in this case, proximal to the stone. Okay, this is the easy one. Then this much easier. Everyone at least saw it one time. When you have like, yes, radio opaque, yes, stone. So it is in the urinary bladder probably. So it is bladder calculus. And this one is you will find it in the pediatric age group probably, and you should search for other associated anomalies. So Abbas, yes, this is what is called neurogenic bladder. Yes, neurogenic bladder, and you can note here that there is absence of, there is dysplastic or agenesis of the sacrum. Perfect. So you cannot see the sacrum. So there is sacral agenesis. So search for other anomalies as well. So neurogenic bladder is common to see in the pediatric age group. Check it. Then you have in the CT this appearance. I hope that the image is a bit clear. So this patient is young woman, and she developed to you in one of your nights in radiology emergency and come to you with abdominal pain. So what is your differential? Yeah, it will be something called striated nephrogram. Ala, Ines. Yeah, Rihan, yes. Striated, Dr. Muayyad, yes. Striated nephrogram. So this suggests to you to be acute pyelonephritis, acute pyelonephritis. So you can see that there is maybe some diffuse enlargement. Sometimes it has persistent nephrogram. Maybe it's some attenuation of the calyces, present in this case, maybe. But the most important to see that the wedge-shaped decreased enhancement radiating to the capsule. So then you can think about something called acute pyelonephritis. I see that Rehan suggests also some of the good differential, that it can be renal vein thrombosis. It can be, yes, urethral obstruction, perfect. It can be, so obstruction, venous thrombosis. It can be also with the wedge-shaped appearance. If it is non-enhancing, it can be infarctions, perfect, multiple infarctions, hypotension, yeah, medullary sponge kidney. We have many things. So this is what's called persistent or striated nephrogram. Yes. Okay. So when you find this one, what it will be, your differential. Yeah, there is no differential. Yes, I would like to say that is very important to know. So it is emphysematous. So any air in your body, it will be very dangerous to mention. So it is emphysematous pyelonephritis. Sure that in FRCR, they will not show you easier one like this. They will show you an X-ray and probably it will be subtle. So they will ask you to discriminate it. Yes, it is emergency again. The hand nice. So any air, don't forget it. It's very nice. It's very important. So what about this image? Intrarenal, something, lesion. But this lesion, I see that many of us rush to the infection, maybe abscess, yeah. Because you can see that there is distortion of the renal parenchyma and multiple areas non-enhancing, and Ala mentioned that it is fat stranding as well. Yeah, Rihan. So if you find the stone and fat density, which much, yeah, so you can mention them too. But this one, it is like just abscess, so it is pyelonephritis complicated with abscess, yeah. And maybe you can show you this one, which is similar, so you can see again that's lesion, focal lesion. Sometimes it's confusing to be like renal cell or others. So take care. So one of the good differential abscess. Sure that the clinical here will be helpful. If this patient have any clinical history of predisposing factor of abscesses, then you can think about it. Okay? Yes, sure. So the clinical will. So let's go back. I want to show you something until everyone come back. Okay. So let's start with this case. Okay. How to hide this? Okay. So let's have a look in this case. Yeah. This patient is like 72 years old. History of something. Let's be surprising you. You can see any uptake. Look in the CT as first. This is non-contrast CT. Then you can see after the contrast how it look. So don't rush in differential hand. Let's first to go to the, yeah, to go to the description. So you can have like hypodense lesion here and also here. So it's bilateral, perfect. So, and when you go to the FDG, very high. So very high avid uptake. I say that you go directly to lymphoma. Yeah, perfect. So let's go to the history now, and I will mention to you that this patient have history of treated scalp sarcoma. So now what is your differential? Maybe, but as you know, that is not very typical to be metastatic scalp sarcoma or any sarcoma that to go to the kidney itself, right? So do you like to take biopsy in this case? It will be your next step to take biopsy. Yeah, if you take biopsy, what do you expect? Yes, what do you expect to see? As Rihan told us from the first, it will be with this very high uptake. It can be what is called lymphoma, renal lymphoma. Yes, B-cell lymphoma. It is lymphoma. Yes. Okay. Let's go to this case, and you can see that the kidney here is involved. So this is like a young age woman which have something, and try to describe. Is it the image is clear, or you want to be more large? No. Let's go back. Sorry. It's better to. Okay. Is okay like this image? Sorry about the. Yeah. So let's describe this retroperitoneal lesion, which involves the kidney itself, and as you see here, it go and involving the adjacent bones, the ribs. Okay. So the question here, that is it 2 patients or 1 patient? This is 1 patient. So what happened? He take what? So which one is the baseline? We can ask it in another question. Which one is the baseline imaging? And which one the after 2 cycles of chemotherapy? Okay, so this patient have the same patient, but he take like the chemotherapy treatment. So which one is the baseline? This one, and this one after. So do you agree that the RCC take chemotherapy? Do you figure it like this? Maybe yes, if it is metastatic. But if not, they give it like what? They make surgery, right? Yeah. Most of condition they make surgery. Okay. So let's describe first as step by step. So this involving the right kidney and go, and you can see the bones infiltrated, maybe the right adrenal also is involved. You can see this. Sorry, the left adrenal is involved as well. And all the right kidney, yes. And yeah, very nice. That if after 2 cycles of chemotherapy, this patient respond very good. Okay, so I will check the answers now. Okay, so what do you differential? I see many differential now, but I wait you to give me one differential. So after he take this treatment, do you remember when I told you that the patient in the bone marrow, he have something called hyperplasia after chemotherapy? Can you recognize it easy? Look in the spine and the pelvis. Yeah, you can see that this is like expected to have something called bone marrow hyperplasia, right? So there is no metastasis here or no infiltration. Perfect. Okay. Maybe there is some uptake here after treatment. Yeah. Okay. So when you see, yeah, Huda, welcome Huda. Nice show up with nice differentials. Thank you. So it can be what is called lymphoma. Yes. This is very common to lymphoma to include the kidney and the retroperitoneal region. You will see it in practice much common. And after treatment, you can see this marvelous response. That's why in the lymphoma, if you suspect lymphoma, you should put it like in your top list of differential. Why? Because you can give this patient treatment, and after treatment, he will have marvelous response if he take the suitable chemotherapy. So this good example, and a good example also for the pitfall of hyperplasia, bone marrow hyperplasia, that it is, yes. He wants to show you to also that they mentioned that there is some residual focal uptake in the left proximal femur, and maybe it was suspicious in follow-up. And what he wants to show you here, what is this? Can you imagine what it could be? No? It is, yeah, it is difficult, but yeah, it is something benign. So it is, okay, we'll wait 1, 2, 3 seconds, 4 seconds. It is inguinal. Yeah, something like this. It's inguinal hernia, and it have part of the bladder. That's why it's very high uptake, similar to the bladder. So this is like right inguinal hernia. And it was here, as you see, but it's become bigger as here the bladder is very small uptake, excretion, and here is a bit full bladder. Yeah, very tricky. So take care, yeah. And I like this type of cases because it teach something. Okay. So FDJ, let's T cases. Let's go to this case, which is a bit longer one. Okay. If someone want to talk, he can talk, sure. We like either text discussion or voice discussion. So what happened here? Again, this patient we can take it easy now. It's lymphoma, perfect. So what happened with lymphoma here? Let's start with this A, which is one patient, and this B, another patient, third patient, fourth patient. Let's go with this one, and you can describe the uptake. So the uptake here is bilateral in both kidneys. Where it's else? Where is it is else? Which place, site do you would like to mention? It is in the retroperitoneum. Perfect. So it is retroperitoneal. What? Where? Lymphadenopathy. Perfect. So retroperitoneal lymphadenopathy. Yes, and the IVC maybe it's compressed, but lymphoma it doesn't involve the IVC itself. Like it's not typical to go inside the IVC. It's just compression or like displacing. Yes. So let's go to this one. What you have here, is it unilateral? Do you agree that is unilateral? Yeah, unilateral renal mass. And what you have here again? Lymphadenopathy. So again, lymphadenopathy. Nice. So this another similar case to the first case I show you. What happened here? It takes almost the left kidney. Yes, is invading the left kidney, and again there is some retroperitoneal lymphadenopathy. Perfect. Finally, this one, it is taking the both kidneys with diffuse infiltration and retroperitoneal lymphadenopathy. Okay, so another case. Let's take it more quick or more faster. What happened here? Perfect, right renal. So right renal, and what happened here? Why do you see this appearance? Yeah, you have uptake in the right kidney, which is lymphoma infiltration, and there is some dilatation with excretion. Yes, ureteric excretion. Then it will be, yeah, your rule, if you remember when we deal with the urinary system, you should make windowing, like what we did in the previous session. Yeah, you make some windowing to change the window of the SUV. Then you can know, is it like secretion or it is like soft tissue, which is different. Yeah, so it will be like ureteric involvement or just ureteric excretion. Okay, so it is like involving the almost the right kidney, and it show progression as you see here. It start like this, and after maybe a while, I don't know how much months he have, but this was baseline, and this is like the follow-up of this patient. So you can see clearly that this patient, what happened here, regression or progression? Yes, it have after 1 month, it is progressed. Yeah, and you can see, yes, perfect. Okay, let's have this one and finish with so this patient have history of something called myeloid sarcoma. So how you describe it? Where is the uptake, abnormal uptake, and the extensions? Yes. Do you agree that there is retroperitoneal lymphadenopathy? Do you agree? Perfect, Rehan. Yes. Do you agree that there is also some mesenteric lymphadenopathy? Yes. Okay. So in this PET-CT images, you can see this. Okay. And sure that now the most important to mention that there is right renal and perirenal extension, yeah, involvement. Yes. Okay. And you can note that there is bilateral renal stents. Yes. Maybe this what make you hear the appearance of this, yeah, stents. Yes. Okay. So this what's called myeloid sarcoma. I think this is like similar to leukemia or something. Yeah. So this one is solved because I show you the answer. Okay, but already this patient you can describe as that bilateral. You can see that there is renal enlargement. Do you agree with this? Enlargement of both kidneys. Yeah, that's the most important in description to mention that in. And here, if you want to mention the uptake, you will say that focal uptake as previous cases, or you can say diffuse uptake. Is it the kidneys? Yeah, diffuse uptake. So you have here diffuse high uptake. This patient already have history of leukemia, and he developed renal failure, acute renal failure. And you can see again the retroperitoneal lymphadenopathy. So this is what it is: lymph infiltration of leukemia. So leukemic infiltration. Okay. Yes, leukemic infiltration. So let's go to this case and imagine what happened here. Yeah, it can be lymphoma. Yeah, it can be lymphoma. Yes, in the previous case. Yeah. Okay. So what happened here? Let's try to describe. It is have multi findings. Try to collect the finding first. So one of them, it was like a baseline, and one of them, it is like follow up. Yes. So one of them, it will be this one is the baseline, and this one, it will be the follow up. So what happened here? Renal, nice. Renal uptake. That's why it choose to be in this. So we have renal uptake, and you can see that there is progression or regression. If this is the baseline and this is the follow-up, it is progressive. Perfect, Nermeen. Yeah. So there is metastasis or infiltration. It depends. Is it lymphoma or there is primary progression? Yeah. Do you see any other abnormalities? Left axillary. Perfect. And there is progression of the mediastinal as well. So axillary and mediastinal, or maybe lung, also. Yes, so maybe lung as well. And yeah, so maybe you can think about primary, and your primary here will be the, yes, the breast. So the liver involved, and it is progressed with new invasion. Yes. So you can see that the breast cancer here, it will be the primary source in this case. So it can involve the kidney, as you see, the liver, mediastinum, and lung. So this is a progressive disease. Primary, it will be breast cancer. Okay? Yeah. And it is progressive case. Yeah. Let's have a look. Do you enjoy, or we can go back to our conventional imaging? Okay? Okay, let's take this last case and go back to, because I don't want to burden you with this hybrid yet. Okay. So what happened here? What you have, right? Hilar uptake. Nice. And you can say it's like maybe hilar, maybe right upper loop. You can see the CT image and check it. Where is it exactly? Yes. So this one, it was the baseline. Yeah, and this one, it was the follow-up. So what happened here? Rihan, yeah. It sent to the kidney in the follow-up. Where it sent from the lung. Yes, Rihan, perfect. Progression. Again, it's progression, yes. So it have, he take like chemotherapy, he take like radiation. Yeah. Yeah, with metastasis. You can see even the CT, there is obliteration of the renal cortex and the fat sinus. So this is like left renal mass, which is metastatic. Yeah. Okay, this patient, your suggestion would be that is like lung cancer, and you can see the lymphadenopathy and the kidney involvement in this case. Okay, come back. Let's come back. So what do you see here? How we describe it? Okay. Yes. Which thing? Okay. If I ask you, what do you expect of this patient in the history? What he have in the history? What do you expect to have in this history? Perfect. So you will go to check the differential diagnosis, which include, yes, analgesics, and include diabetes, Rihan, nice. And this description, multiple bilateral filling defects. Yes. So this have what is called horns, ring shadows, Egen cup, ring sign. Yes. So what is called renal papillary necrosis. So we are describing this appearance of renal papillary necrosis. What is the differential? Will be sickle cell, as you mentioned. Yes, mean, and pyelonephritis, obstruction, TB, trauma, cirrhosis, analgesia. They have what is called postcard. Postcard, and you can save it. Don't forget, as I see many stars, they mentioned that don't forget sickle cell and analgesia. And sure, this patient was diabetic. Sorry again. Sorry again. Okay. So this patient was diabetes, yes. And they have many appearance. Yeah, so this one should be the normal. And if you have central excavation, it will be what is called ball and T appearance, or pharyngeal extravasation, or excavation, or lobuster clue appearance, or signet ring appearance, and finally sloughed papilla with club decalysis. Yes. So everyone know this from the the text, and it is like conventional appearance, golf ball in a T. So go back and try to recognize which one of this. So maybe you can say it's ring shadow, Egen cup, yes, or ring again. So what about this one? Lobuster, lobuster clue. So this is renal papillary necrosis with lobuster clue. What about this one? It will be T on pole. Yes, T on pole. Perfect. And what about this one? It will have what is called signet ring appearance. Perfect. Kareem, welcome back. Okay, and what is this about this one? It is planted with club decalysis. It is, yes, clubbed, yes. So you have many different appearance. This one we mentioned it many times, even the practice very easier one. And the history of this patient will be that maybe he have mass hypertension, he have what is called autosomal dominant polycystic kidney disease. So he have renal failure as well. Do you expect to have renal cell carcinoma in this patient? Yes, okay. So what do you expect in the brain? What you have in the brain? This is MCQ question. They like it to bury aneurysm. How much percentage maybe? If someone know, it is about 15%. Yeah, nice. Yeah. And sure that if you go to the liver, you can see some cysts in the pancreas as well. So this is what's called adult polycystic kidney. Bilateral cysts, renal disease, one of the most important diagnoses that you should, the adult dominant polycystic kidney disease. Yes. There is one called acquired. There is one acquired, yeah. And they mentioned that the risk increase in the RCC with this acquired type. Okay. In the text here, they mentioned that there is no risk with the autosomal dominant one, but the risk increase with the acquired one, with dialysis. Yes, perfect. Okay, something good to know. Now, after you see the retroperitoneal lymphadenopathy, sure that you will put in the differential diagnosis. The most important one, it will be the lymphoma. Yes, but here, even in the BCT, when you find this appearance, what you are going to check? Nirmin, nice, Ala. Yeah. So when you find this appearance, especially in young patient, you will go to check the testes. So which one, like the major one, which send testicular, which one with the testicular tumors send this retroperitoneal? Seminoma. Yes. So you are going to check the seminoma. Yeah. So germ cell tumors, you are going to check the tests to see if there is any germ cell tumor as seminoma. This is very common scenario that you should know it. When you find this, you will put other differential diagnosis like lymphoma and so on, but don't forget germ cell tumors. Seminoma, embryonal cell carcinoma, which is more aggressive, and choriocarcinoma, and teratomas. And also the sex cord tumors as well, like Leidige Sertoli cell tumor. Okay. The metastasis, as we mentioned, from prostate or kidneys, they can send here, and lymphoma and leukemia, as we mentioned, it will be your differential diagnosis. But if it is young patient, then you should put testicular neoplasm as a first differential diagnosis. Okay, don't forget it when you put testicular neoplasm. Nice that you everyone know it. So this is good information. This one is easy. They like it in the spotting as well. Yeah, I don't see Marwa as well. I don't know where is it. Nirmin Muhammad also, she didn't show up today, but okay. We have new stars, but we need our stars before. We would like to show up and to dance. So this one is medullary nephrocalcinosis, which is common. Yes, Ala, Kareem, yeah, everyone. Rehan, Ines. Okay. And you are going to think about, yes, hyper, bara. The most common cause in adult will be hyperbara. Perfect. Medullary sponge kidneys. Yeah. Other causes like Lasix in infants, if this patient is infant. And they like to show you this one as appearance of what is called cortical nephrocalcinosis. And you can see the causes here. Yeah. Cortical nephrocalcinosis, pelvic kidney or transplanted kidney. And you can see that acute cortical necrosis and transplant rejection as well. cortical nephrocalcinosis. Okay. So again, in the ultrasound, if you are lucky, you can see this appearance, and in the CT, you can see this appearance. Huda, okay, thank you, Huda. Nirmin, yeah, our usual stars. So this one, it will be again what is called this one and this one. It will be calcified pyramids, and this patient have history of sarcoidosis, medullary nephrocalcinosis. Perfect. So this what's called medullary nephrocalcinosis. Yes. What about this one? Everyone like it with this appearance. The IVB. Where is Ivan? Ivan today is absent as well. Yeah, I know our stars. I don't know. Okay. Toothbrush appearance. Okay, so it is what is called medullary sponge kidney. So what happened with the calyces, the renal collecting system? There is some dilatation of the renal collecting system, tubules, something called ducts of Bellini. Yeah. You expect it will be young or old? He will be young adult. Yes. Incidental finding, and maybe he developed like UTI, calculi, and so on. Perfect, Ala. Again, another appearance of medullary sponge kidney. Okay? Medullary sponge kidney. Yes. Okay. Okay. What happened here? You expect to ask the patient or to see in the history of this patient renal trauma, renal fractures. Then the question in the textbook about the grades of renal fracture. Yes, grade 1, which is, yes, grade 2, grade 3, 4, and 5. So you have the grades. Let's talk about the grades quickly. Yes, so this one, it will be grade 1 or 2. Grade 1. Why grade 1? Because it is maybe just some contusion, and there is hypoenhancement, ill-defined hypoenhancement in this kidney compared to the other, and the subcapsular hematoma. Perfect. So type 1. So what about this one? With again perinephric hematoma. But what happened here? Why grade 2? So it is subcapsular hematoma again, but what? There is renal injury, subcapsular, and perinephric hematoma. Yes, perinephric hematoma. So this include the left perinephric collection. So the first was just subcapsular. Yes, just subcapsular hematoma. The other one extension. Yeah, less than 1 centimeter. So this one, it is more extension and go in the perinephric space. I see Ala also add that it doesn't involve the pelvis. Okay. So what about this one? It will be, yeah, there is here renal laceration. Again, perinephric, but there is renal laceration. Perfect. So this one, it will be 3. Okay. And there is this one, which is 4. Yes, still not involving. Yes. This one will be 4. Yeah. And finally, this is what is called 5. When you have laceration extending to the collecting system, the pelvis. Yeah, involve the collecting system. Yes. You can see in the excretory phase. Yes. So this one, it was good. Okay. What happened here? Yes. Yes. You can see the injury here, that the main renal artery. Okay, the renal artery is in the trauma is involved, and as you see, the kidney enhancement is finished. Go. There is no renal enhancement, and this is what is called pedicle injury, grade 5. Yeah. Perfect. So nice. I hope everyone enjoyed today's session. And this is grade 5 again, shattered kidney. As I hope everyone doing well and enjoyed the session. And inshallah, on Saturday we continue. Okay. This one also grade 5. It involved the renal pelvis, and as you see here, there is avulsion, UBG avulsion. Yes. Inshallah, next day, MacBook. Okay. Inshallah. Okay. See you then, inshallah. And if any comment